Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on tuberculosis or TB contact investigation, principles, and practice. My name is Leanne McDonald. I'm a public health physician here at Public Health Ontario, and I have the pleasure of moderating today's session, which I know we're all looking forward to. I'll begin with a land acknowledgement. We acknowledge that the land we are facilitating this virtual educational session on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto, where I'm seated today, is covered by Treaty 13 with the Mississaugas of the Credit, and that we all continue to strive toward efforts to engage with Indigenous partners, listen and learn and work toward reconciliation, including in respect of TB work, which is the topic for today. So I'll now turn my attention to a few housekeeping items before introducing our speaker. So as per usual, if you've been to PHO Rounds before, the chat pod has been disabled to limit any distractions during the presentation, but please do use the Q&A pod if you have questions during the session, and then we will have a discussion and question period following the presentation, but you can enter those questions throughout. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. And as moderator of today's session, I don't have any conflicts of interest to disclose, but just certainly I am employed by Public Health Ontario as a public health physician and have also received some CIHR-funded grants as a co-investigator and travel support to attend public health preventive medicine residency program events. So now it is my pleasure to introduce today's speaker, Dr. Elizabeth Ray. Dr. Elizabeth Ray has been the Associate Medical Officer of Health with the Tuberculosis Program at Toronto Public Health since 2005. She's the lead author of the Contacts and Outbreaks chapter of the updated 2022 Canadian TB Standards, 8th edition, co-chair of the national advocacy group Stop TB Canada, and she's an adjunct professor at the Dalla Lana School of Public Health, University of Toronto. She's been involved in TB policy issues for many years, and her research interests include TB epidemiology and operational research in TB programs. It's a pleasure to have you, Dr. Elizabeth Ray. Welcome, and over to you.
Thanks very much. And thanks to everybody who logged on. It's really gratifying to see so many people interested in this. I should start by saying this is my presentation. I'm not speaking on behalf of Public Health Ontario. And like Leanne, I have no conflicts of interest to disclose. And I guess I should also say, like, I stand on the shoulders of giants. But to start this off, I want to thank all of the many public health TB nurses and clinicians and epidemiologists, and also patients and contacts that I've worked with over the years, because this is very much speaking from a collective experience and a collective global literature on this as well. So I am really pitching this two things. This is not a TB 101 talk. So I'm going to assume that everybody's comfortable with what is TB, the real basics about diagnosing TB, and why we worry about TB, that kind of stuff. But it is a TB contact investigation 101. So I'm going to be speaking fairly broadly and high level, and it really is intended as an introduction to TB contact follow-up. So I'm going to start, like many rounds, with a typical Ontario TB case. So this is a 32-year-old who immigrated from India 5 years ago, so not exactly a newcomer. Previously healthy, but about a month-long history of progressive cough, fatigue, loss of appetite, and now fever and night sweats as well. On chest x-ray, he's got right upper lobe infiltrates and opacities, but no cavities. His sputum smear is 3+ AFB. It's PCR positive for tuberculosis, and it was culture positive at 11 days, and is pan-sensitive. So that's that's a pretty typical TB case in Ontario. So what I want to talk about now is really kind of, and so now you've presumably, the person with TB has got diagnosed, they're getting into care, they're getting treatment, and what is all the contact follow-up, contact investigation about? So this diagram is trying to show a little bit the natural history of TB. So someone is a susceptible host, they get exposed to TB. Over a lifetime, they may progress to becoming an active case themselves. That risk is highest in the first 5 years or so, especially the first couple of years, but there's a lifetime risk that people may go on to develop active TB. So contact investigation is trying to break that chain of ongoing transmission of tuberculosis in that sort of blue arrow period of things. It's focusing on the time after people have been exposed and potentially infected, but hopefully before they become ill themselves, or at least if they've already become ill themselves, is hopefully very early. So contact investigation is trying to break the chain of transmission and limit morbidity to people who've been exposed. So the goals of it, the overall objectives of contact investigation, are early detection of secondary cases, because some of those contacts may already be ill with TB, to find a source case if the index case of person who showed up with TB is a very young child, and detection and treatment of latent TB in the pool of contacts to prevent them going along that lifetime arrow towards potentially becoming an infectious case themselves. So okay, why do contact investigation? I kind of said what the objectives are, but contact investigation is, broadly speaking, is recommended by the WHO worldwide, particularly for households and particularly for young children exposed. But it is an essential component of the WHO framework for TB elimination in high-income countries, which includes Canada. So it is a core component of TB programs across Canada. It's the hands down the highest yield group for active case finding for TB. I put there the prevalence of active TB among close contacts is 1 or 2,000 per 100,000. The rate of TB in Canada whole is 5 per 100,000. So it's a very, very high yield group if you're trying to find active cases. Multiple studies have shown that contact tracing, including treatment of TB infection for contacts, is cost effective. And in modeling studies, household contact investigation may contribute significantly to reducing TB rates over a period of time compared to not doing contact investigation and follow-up. But I want to emphasize, it will only bring the rates down if it also includes that loop to treat latent TB infection in people that are found to have. And I put a couple of links there below for fun bedtime reading if you're interested in some of those issues. Okay, so I'm going to talk a lot in this webinar about systematic approaches. So this is a really high level kind of to-do list for contact investigation. I'm really going to be talking about the first 2 steps of that. So how do you do a risk assessment for TB exposures? And then how do you define and prioritize which contacts you want to follow up? You could do whole other webinars. You could actually do multi-day workshops about the whole thing. I'm really going to be focusing on the first 2 in this talk. Okay, so here's a really basic framework for TB risk assessment for contact investigation. So first off, how infectious is the index patient? over what period of time do we think they were infectious? And in what settings did those exposures happen? And then for each exposures is a bit of a exposure setting risk assessment that happens. And then you pull that all together and then you try and prioritize contacts. So I want to talk a little bit about over what period of infectiousness. So honestly, there is no actual good studies that have proved this. That would be a totally unethical study, you can imagine, to take someone that you thought had TB, wait for them to get more and more infectious, expose new people to them on purpose, and see at what point contacts became infected. So this is the whole thing about once somebody's diagnosed, how far back should you go? That's all expert opinion. The general recommendation is to start, as your kind of start point, the earliest point at which you thought somebody had TB. So that might be onset of symptoms. It might be the first time there was an abnormality on chest x-ray. It might be the point at which a sputum sample was taken. But find that earliest point where they were in theory diagnosable. And then if they presented with cavitary disease, go back 3 months from that. If they presented with minimal disease, smear negative, no cavity, go back 1 month from that. If they were smear positive but not cavitary, you could go back for 2 months. Okay. And then the end point is, when did the person stop being in circulation? When were they in isolation from other people or no longer infectious, whichever comes first? So only respiratory TB is infectious. TB is spread through the air. Wherever TB is in your body, it's only going to affect other people if it has a way to get out into the air. So almost all the time, that means TB in the lungs or the airway, laryngeal TB. There are some very rare exceptions where you can get TB inside somebody's body to the outside. That would be things like TB of a hip joint, and an orthopedic surgeon goes in there with a saw and it aerosolizes infectious TB material in the operating room. In daily life, obviously that kind of thing doesn't really happen. So in terms of community contact follow-up, it really is respiratory TB in the respiratory tract is what we're worried about. TB is just not exquisitely infectious. It really does take close, prolonged contact with someone who has TB in their airways. People are more infectious if they are smear positive. That little microscope slide there, if you enlarge your screen enough, you can see little pink squiggles. Those are TB bacteria. If there's enough TB bacteria in the sputum that you can actually see it under a microscope, that's more infectious. People with cavitary TB in their lungs are more infectious. That X-ray and a CT scan there show a little bit what a cavity actually looks like. It really is a hole in the lungs, and it's full of a slurry of dead cells and bacteria. So every time you cough, it's like jumping on a tube of toothpaste, squishing out all of that infectious material out into the air. So people with cavities are clearly more infectious than people without. It would be easy to think that people who are coughing are more infectious, and they kind of are overall, but coughing is actually not a great predictor of infectiousness, probably because there's a lot of variability in how good different individuals are at generating those droplet nuclei. So broadly speaking, if people have a cough, they're more infectious, but it's not actually a good predictor of infectiousness. And young children are rarely infectious. And by young children, I mean pre-puberty. That's partly because they're often diagnosed very, very early through contact follow-up, and partly because they're less likely to develop cavitary disease. And those very infectious, more adolescent adult presentations of tuberculosis. Having said that, if you do have, a 5-year-old with cavitary disease, they're infectious. Okay. So in real life, um, uh, this is me on this theme of variability. In real life, like we talk about, an untreated case of tuberculosis can infect 15 new people per year. That's, that's spread over 365 days. So on any one of those days, the person with TB isn't spectacularly infectious, right? It's because people can be ill for quite a long time before they're diagnosed that's an issue. About 1 or 2% of close contacts already have active TB at the time of the contact investigation. There have been a bunch of estimates about how many people really are infectious. This is one estimate, but I think a good one. Probably only about 1/3 of people with respiratory TB are functionally infectious. Problem for those of us doing the contact follow-up is there's not much way to distinguish between them right now. So up front, you don't know. So as an example, these are 2 Toronto situations that look identical on paper. Cavitary 4+ tuberculosis, ill for an extended period of time. And in one situation, the person with TB had 5 household contacts. By the time they were diagnosed and we were doing contact follow-up, 3 of the 5 were already secondary cases. And then another person who looked exactly the same on paper didn't transmit to either of her household contacts, including her 10-month-old baby that she co-slept with. So go figure. Another big piece of variability and infectiousness is, again, that idea of smear positive, smear negative, and how close was the contact. So this is a study that was done quite a long time ago now, but in Canada. And it shows like the big difference between the proportion of contacts who have a positive TST, depending on whether you're smear positive, which is the group on the left, compared to the index case being smear negative on the right. So it's a good, 3 times difference there. And same again for between close contacts and people who had only casual or sporadic contact. Big differences in how infectious people are. So that's very different than something like measles, where we kind of say anybody who was in the airspace for any amount of time is likely to be infected. Okay. So exposure times. In theory, there's no exposure without risk. In practice, it actually takes lots and lots and lots of time. There have been some really great studies in the US, which is a lot more comparable to our situation in Canada, but also in some other settings. And outside of household exposures, it really does take 120 to 250 cumulative hours in most settings to catch TB. So we're really not talking about, passing somebody in the hallway or sitting down with somebody for an hour once. We're talking about substantial cumulative exposures. There are some exquisitely risky situations like aerosolizing procedures in hospitals. We do also tend to be extremely risk averse in following up hospital patient exposures. But that's again one of those, expert opinion or maybe expert anxiety, really being cautious about trying to define a risk period to do contact follow-up. So in most settings, we're talking about well over 100 hours of cumulative exposure. Okay. So the other thing is that TB is airborne, and that means that ventilation matters a lot. So coming out of COVID, there was a lot of conversations during COVID about crowding, about ventilation, and that is absolutely true for tuberculosis. as well, even though we're talking about much longer time periods. So places where there's crowding, not lots of ventilation, and lots of time in the same airspace, those are higher transmission risk situations. And even though TB is airborne, like it really can travel through ducts out of the room to another floor, that kind of thing, there's still a plume effect. So if I have TB, right around me, those particles, those droplet nuclei are much more concentrated. As it gets further away from me, it's much more diluted out. So the risk is, even though it's airborne, the risk is always going to be highest closest to the person who has TB. And this is where, trying to get a sense of all these ventilation issues, a site visit is absolutely invaluable to actually figure what's going on. So I put some photos down at the bottom of there of like a super crowded bunk bed room. So people are staying there, at least overnight, all jammed into one room at very close quarters, versus a public swimming pool, which is a massive, massive airspace, where people are quite spread out, and hopefully not spending the night. So these are some high risk TB transmission situations. And these are all things that are well documented in the literature, that have led to TB outbreaks. So there's a real theme here about crowding in small spaces, with not lots of ventilation. In real life, these are the kind of things that you're looking for as red flags, that would be higher risk situations where you might be more aggressively doing contact follow-up, even with less exposure time. So into some of the practicalities, TB is a slow infection, so contact investigation isn't the kind of urgent that it is for some other respiratory viral infections. But it is reasonably, so it's not an emergency, but it is reasonably urgent, partly because of that issue that some contacts may already be secondary cases, and households are particularly at risk for them. So current recommendation is that the first interview of the person with TB to figure out at least who their high risk contacts are should happen within the first 1, 2, 3 days of diagnosis. And that initial focus is really about the high risk contacts, so household members or similar, and making sure that none of them are ill. If they are, get them assessed as soon as possible. And within a week or so of the person with TB being diagnosed, the actual screening of those people. So actually talking with them, doing a symptom review with them, making arrangements to get skin testing or chest x-rays or whatever it is done for those high priority contacts, and to aim to wrap up that first round for the high priority contacts within 30 days of the case being diagnosed. So not an emergency, but like not something you want to leave for a long time either. All right. You could do, again, like entire workshops on contact interviewing. It really is a skill, which means it's learnable and something to practice. Motivational interviewing techniques are incredibly helpful, but so is culture and language and local knowledge really, really important to be able to ask the right questions in the right way to help people feel comfortable talking about who their contacts are and who might need contact follow-up. Contact interviewing is best done in private. Don't sit down with somebody in a coffee shop unless they really, really want to. In person is always easier to establish that rapport. Home visits are strongly, strongly recommended. some studies have found things like if you do contact interview as a home visit, as opposed to, come into our office and talk about it, you find an average of 2 additional close contacts by doing home visit based interviewing that way. Language is absolutely important. When people are unwell and anxious, it's really difficult to function in a second or third or fourth language. So use a professional interpreter if you need to. And it's also worth remembering you don't have to do this all in one visit. For most people, it takes a few visits to feel comfortable, for the panic levels to step down, and get a full picture of contacts. Again, systematic approach. We talk about where do you live, where do you play, where do you work, where do you pray. So that's a nice little kind of catchy mnemonic there, but also smoking, healthcare exposures, transportation, travel, special events. You can ask those questions as lists, like give me a list of your household members, but it's also really useful to ask about locations. So it's Monday morning, where do you go? And base the picture around like helping people walk through in a normal week. Where do you go and where do you go next? Okay. So hopefully by then you have a list of settings, and this is another framework for exposure setting risk assessment. So within that period of infectivity, you want to try and figure out, okay, how many hours of exposure happened in that setting? How close was the contact to the person with TB? And then for the setting itself, how big is the airspace? What's the ventilation like? How crowded is it? Because those are all things that are going to slide your level of risk up or down. So here's our typical case. Here's a list of their contacts. That's potentially a lot of people, from household, close family that they see a lot, a best friend, weekend soccer, place of worship. And I put 3 different choose your own adventures there for where they work. And those all have different, setting risk assessments that you would think about. And this is not unusual, right? So for any one person, you could have potentially dozens and dozens of potential contacts to think through. Is it a risk? Is it not? Do I need to do contact follow-up for this group or that group? All right. Because I had put one of the choose your own work adventures was that the person with TB is a early childhood educator at a daycare. Kids are much more vulnerable to tuberculosis. It's easier for them to get infected, and it's also much easier for them to develop disease much more quickly because their immune systems are still developing. So when we talk about TB transmission in kids, we're really talking about very young children. So for sure under 5, and especially babies under 1. So they're a higher risk group at a lower level of exposure. So it's another complication when you're trying to work through all of these frameworks. And there's another group that's also vulnerable, often at the other end of the age spectrum. So people who have immunocompromising conditions, which might include age, extremes of age, but also diabetes, dialysis, oncology clinics, HIV, people that are on immune compromising medications. Those are also people that are at higher risk with lesser amounts of exposure. And in particular, if you have a person with TB who goes into those kind of high risk medical clinic settings, that would be a potential concern. Okay. So that's a whole bunch of principles. And then it's really, really important to be systematic and structured about how you go about this. So prioritizing is absolutely essential. It's really easy to lose track and chase hundreds of people with minimal exposure and never have a chance to make sure that the people at highest risk really get the screening and treatment that they need. And here again, I'm emphasizing, like, it's not just the screening that matters. It's not having hundreds of test results. It's having people who need either treatment for active TB or treatment for latent TB actually get that intervention. So it's a whole kind of system that has to go into place. Okay, so we prioritize among TB patients by how infectious they are. So that means we put more resources into contact follow-up for someone who's smear positive and cavitary than we would for someone who's smear negative, at least on the initial go round. And then among contacts, prioritized by the extent of exposure and the immunologic vulnerability of those contacts. So this is straight from the Canadian TB standards. And it's basically saying for your initial contact follow-up, define the size of the group or how many people to follow up by whether your index case is smear negative versus smear positive. If they're smear negative, your initial contact follow-up is only going to include that high priority group that have tons of exposure. If people are smear positive, your initial contact follow-up is also going to include people who have medium priority exposure. So beyond the household or household equivalent, to also include, for most people, this would be like workplace and school contacts. It might include close friends that people see a lot, or boyfriends, girlfriends who you don't actually live with, but see a lot. The really critical thing here is you do your initial contact follow-up, and then you see, well, do I have evidence of transmission? Because you might need to expand it. So this prioritization is really about the initial bucket of people that you're going to try and test and follow up with. Okay. This is also linked in the Canadian TB standards. This is again about having a systematic approach. This is a tool that we developed at Toronto Public Health to try and guide that initial contact follow-up. So again, it's trying to divide people into lower cases, people with TB. Are they lower risk or higher risk in terms of infectiousness? And then trying to go systematically through different types of exposure settings and figure out what contacts would need follow-up and what might that look like. So we use as a rough threshold for people that are, smear positive cavitary, round about 96 hours of exposure as a rough cutoff. For people that are smear negative, not cavitary, more like 120 hours of cumulative exposure as a cutoff. There is nothing magical about those numbers. It's really, to ballpark. Okay. So to kind of show how this might work, for a typical case with the choose your own adventure work options, if they were working for IT in a big bank, I've kind of laid out there 5 days a week, 12 weeks is their period of infectivity. That's a lot of hours of exposure. But for IT, you'd have to think about, are they working remote? Because there might not actually be any exposure at all if they're working remotely versus in person. If they are going into the office, is it an open cubicle or is it a small room? And then if it's a big open cubicle floor, you're probably not going to need to test the entire floor at the first pass. So you'd have to somehow define a group that's sitting closest to the index case. For someone who's a roofer, this is a little bit like the playing soccer outdoors, like the whole job is outdoors. But you would have to think maybe about carpooling, about smoking together, things like that. The ECE in a daycare, that's like hands down, that's going to be the highest risk situation. You can't do ECE toddler daycare remotely, so that's in person for sure with a lot of exposure and a high risk set of contacts that are under 5 years old. So in practical terms, household is about 50% of transmission. So if you're going to put your resources into anything, it's household by that big definition. So living in the same apartment or the same house, but also shelters, jails, any kind of congregate setting, that's household. We do see transmission in school classrooms, especially for high school, but not so much transmission in most adult workplaces, although it does happen, and ventilation and room size matter a lot in terms of workplace transmission. Okay. I'm just going to skim through some stuff about contact testing. It's really important to have a clear clinical pathway for contacts for the medical care that they actually need. So it's rule out active TB and then deal with latent tuberculosis infection. So everybody needs a symptom assessment. If they're asymptomatic or they were symptomatic, but you've ruled out active TB, then you need to deal with TST or IGRA. Anyone who's positive needs a chest x-ray and offering TB preventive treatment. So a really clear pathway to get people right to the finish line with this is an important part of that systematic approach. Here's a tangle. It can take up to 8 weeks after exposure for a TST or an IGRA to become positive. So that means you have to figure out when the break-in contact was for the specific contact, and then time the follow-up test for them at least 8 weeks after that break-in contact. We tend to do an immediate and a post 8-week test for household high priority contacts. For a lot of workplaces and schools, in practical terms, it often works out to be better to only do the post 8-week test. So 1 round of testing rather than 2. On the other hand, if you're talking about those daycare kids, you might really need to think about initial and post 8-week, depending on when the break-in contact was. It's really important to remember that TB is a very stigmatized, often terrifying disease for people. And whenever you're talking with contacts, workplaces, schools, you have to remember that context, that people are going to be hearing all of this, and deal with that aspect up front. People often need a lot of reassurance and basic information about TB. And by the same token, it's important to be practical about making all of this contact follow-up care really accessible for people, especially in a day where lots of people don't have a family doctor. Lots of people can be juggling 2 jobs just to keep food on the table. So, making time for that contact follow-up testing in a practical way is an important piece of planning out the contact follow-up strategy. By the same token, documentation is the bane of all of our existence, but it is really critical to be able to track all of the contacts and be able to look at their outcomes as a group to make that decision about, do I need to expand contact follow-up? So line lists are another key tool for contact follow-up. Most people will have heard about IGRA testing as an alternative to TSTs. It's not yet covered by OHIP, fingers crossed, but maybe especially useful for people that have had a BCG. Again, most people should have heard about updates to latent TB treatment. Rather than 9 months of INH, the current first-line recommendations are 4 months of rifampin or the 12-week 3HP regimen. So much shorter options for LTBI treatment. Okay. And again, with the systematic programmatic approach to all this, there's a couple of things that are, this is like TB 301 or whatever, but genotyping is automatically done by the provincial lab for every TB isolate, And that can be really useful to confirm or refute if you think there was transmission between cases, and also to identify potential clusters. So there's definitely, advanced topics that again could be their own entire webinars related to TB contact follow-up. Source case investigation, this is my last slide, I think. We don't do contact and source case investigation very often. Only for kids under 5 where you don't know where they caught TB. A very young child with tuberculosis is a red flag that somebody around them is infectious, as opposed to, an 18-year-old who could well have been infected years ago before they came to Canada, that kind of thing. So it's important for very young children to look for the source case, but even for young kids, only about 40% of source case investigations are actually successful. So we do not recommend looking for the source case for older children or adults or anybody with LTBI. There's such an opportunity cost, and the actual success of finding a source case really only pays off for when the person with TB is a very young child and you don't already know what their source case is. So I will stop there. World TB Day is March 24th every year. If you're in Toronto, Toronto Public Health has done World TB Day events at World TB Day at City Hall for many years. They were on hold through the pandemic, but we're really hoping to do it again next year, and you're all invited.
Thank you so much, Elizabeth, for such a fantastic overview of contact tracing. We have many excellent questions in the Q&A, so we'll get going on those. And if you have questions and you haven't typed them in yet, now's your chance. So I'm going to start with grouping some questions that are really about contact tracing, the main focus, and we'll hope to get to a few other questions as well. But in the interest of time, I'll group a few of them. So we had a few questions about the Toronto Public Health Contact Screening Parameters tool, a very popular practical tool. So one of them was about just where can you access this? And I believe it's in the supplemental material to Chapter 11 of the 2022 Canadian TB Standards 8th edition. And that's in the Canadian Journal of Respiratory Critical Care and Sleep Medicine in the supplemental materials. Is that right, Elizabeth?
That's right. It's an online thing, so it's not actually visible when you go down to the bottom of the chapter. You have to go up to the top of the web page, and there's a little line that says online material. You have to click on that, and then it'll pop up.
So it's great that is a resource available. Then we had a couple of participants wondering, were there changes made in the version that is posted with the TB standards, Elizabeth, to the contact screening parameters tool, or will it be updated going forward?
So it changes right now. And hope had already been, the thing that's posted is like version 9 over the years. But right now, that's what we got. And
okay. Sir, go ahead.
People have adapted. Totally welcome recommendations or questions about it. It was clearly developed in Toronto for a Toronto built environment and the way people live in Toronto. So you may have different.
Okay, thank you so much. So I'm just going to paraphrase. We had a little bit of audio variability there, but to paraphrase, the posted version of the contact screening parameters tool that's accompanying the Chapter 11 of the Canadian TB standards is the current most available one, and that you're open to suggestions or input and cognizant of the origins of this in Toronto. Great. So to move on to some questions about conducting contact tracing and in particular contact interviewing. So one question, and I think you started to acknowledge it in your slide about stigma. Do you have any tips for helping with stigma during contact interviews?
Right. So I think the first thing is to acknowledge to people it can be scary, and talk about that up front. But I think also lots of our worries about TB are about TB a long time ago or far away, like real kind of cultural history. So to say here and now in Canada, it's actually not as easy to catch TB in schools. We do a lot of stuff it's very precautionary. It's not urgent. Everything about TB is slow. There's time to get the assessment. There's treatment for latent TB. Even if your child did get infected, there's a very effective way to make sure they never get sick. So dealing with the reasons why people worry about it up front, and also I got to say, being calm yourself is one of the best ways of kind of decreasing the level of anxiety.
Thank you. So another question about doing contact tracing interviews. How do you consider patient confidentiality in the context of contact interviewing and tracing?
Right. So obviously a big issue. A lot of people are really worried about other people knowing that they might have TB. So I'll take this in the context of school and workplace investigations. So it's really important to when you're making a cold call, right? So to a school, for example. So we would normally say, I'm calling from Toronto Public Health. I need to speak to someone in confidence, and one person only, about a public health issue. You'd normally be talking to like the principal, or if it's a company that has an occupational health department, that's who you're aiming for, or a site manager, somebody like that. And when you talk to them, you're saying, I'm going to tell you something in real confidence. This is not to be shared outside. I'm only talking to you because you're the person that has the list of who else was working that same shift, what other kids are in that same classroom, what is their contact information, how do we reach those people. So you're only talking to the person that you have to verify who are the contacts in that site, and talk to them up front about the confidentiality issue. Most like school principals or managers or whatever get that issue, and they also don't want to have like a giant rumor mill and panic about tuberculosis. But it's also important to remember that the person with TB cannot withhold care for contacts, right? It's not up to the person with TB whether or not their close contacts can have access.
Okay, thank you. Those are some thoughtful considerations. We had a question about home visits and PHU staff in respect of IPAC or PPE considerations. Wondering if you had any thoughts to offer on that.
So in general, right now, healthcare workers are being masked, and so when you're providing healthcare, wear a mask. So if you're going to do a home visit to do TSTs, for example, you might very well choose to wear a mask. For sure, if you're doing contact follow-up for TB, you should make sure you have an N95 mask with you. You might easily go into a home and be doing that symptom review and realize, oh, actually, the spouse could very well already have active tuberculosis. So be prepared for that. But I will say, like, when we go into a school to do a screening clinic, we wouldn't normally be wearing a mask, um, that kind of thing, except in the context of COVID, right? Right now, healthcare workers are all wearing masks, not because of TB, but because of COVID. So that's another thing about reducing stigma. If you're walking in with a mask because of COVID, say up front that it's not because of TB. It's because all healthcare workers right now are wearing masks in outbreak season.
Thanks. Let's move on to a couple of questions regarding TST. So the first one was about, would you ever consider in a household contact doing an interim TST before 8 weeks of break in contact? So you've done your initial, would you ever do one in between the initial and the 8 weeks?
I mean, you can always think of situations where it might be important. Maybe that contact is about to go on a trip overseas or something like that. In general, it's that initial and the post 8 week one that matter, especially for contacts who are in the household. They've already had tons of exposure. There's every chance that they will have already converted if they're going to. So it's not very often I'd think about doing an interim. There's always an opportunity cost, right? So the bang for the buck isn't going to be as much for that to add in a third round of testing in the middle.
Thanks. So the next question is about the scenario where it can be challenging to interpret positive TSTs. So do you have any advice regarding assessment of whether the prevalence of positive TSTs is higher than expected?
Right. So that's that idea about, so you're reviewing the aggregate results of contact follow-up to try and decide, is there evidence of transmission? Do I need to expand? I got to say, in Toronto, that's a really tough one. Like, if we do contact follow-up in an ESL class and 70% of people are TST positive, I have no idea if that's more than expected or maybe it's less than expected. That's a pretty tough one, depending on the context. So I realize that's not very helpful, but I worry a bit about taking, published studies that say, well, the proportion of the general Canadian population that are TST positive is 5%. Most of us aren't doing contact follow-up in the general Canadian population. So you need to be careful that your reference population really does reflect the setting that you're testing. So it is, honestly, it's a really tricky one. I would say the best the easiest interpretations are for Canadian-born people who did not have a BCG and are unlikely to have had any other kinds of TB exposures. They're the much more straightforward interpretation that this TST positive is a new one. It really is related to this index case. Sometimes you have those people in your contact pool and sometimes you don't.
Thank you. So we have so many great questions. I want to end with one more question and then a very brief wrap up. So the question is, what is the role of contact tracing in remote Indigenous communities where many houses have no ventilation and are multi-generational, with TB rates higher than in non-Indigenous Canadian-born populations? And, a further question about contact tracing versus community-wide screening. So I know that's a big question, but any thoughts you have in the final sort of 30 seconds, and then we can conclude the session.
Yeah, there are absolutely First Nations communities in Canada, especially northern remote ones, that are in the middle of TB outbreaks right now. A perfect storm of delayed diagnosis, so maybe more infectious people with TB in a context where it's really easy to spread tuberculosis, and often lots of, like, an age structure that means there's lots of young kids who are equally, like more vulnerable if they get infected. So I at this point, years of doing this, I feel a little bit like that situation, those kind of communities is a different ballgame. And much as that's really nice to say, we're going to be focused and targeted in our contact follow-up, in that context, it might need to be a lot broader. Because there are so many settings where it's easy to transmit. The social networks are very intertwined in small remote communities. And absolutely in outbreak situations, community-wide screening may be a very useful tool. There is a whole section on community-wide screening in the Canadian TB standards. I would also say, if you're even thinking of going down that route, call a friend. Talk to someone who's done it before.
So Elizabeth, I think that's a wonderful note to end on. I want to thank Dr. Elizabeth Ray for presenting today. Thank everyone who gave your time and raised such excellent questions. We got through as many as we were able, but we will certainly note the additional questions. You can expect to receive a brief and anonymous PHO Rounds survey for today's session. Thank you for sharing your feedback so we can keep improving our programming. And a friendly reminder that TOPIC, or the Ontario Public Health Convention, will be held March 26th and April 3rd of next year. So details are available on topic.ca. And finally, to access past PHO Rounds presentations and view what's coming up, please visit the PHO website, head to Education and Events, and click on the presentations. Thank you again, Dr. Ray, and thanks to everyone. Have a great afternoon.